TopMedTalk.
Hello and welcome to the second annual POCApalooza, brought to you by TopMedTalk and EBPOM. We are here at the World Congress of Perioperative Medicine 2021. I'm Desiree Chappell, your host, and I'm coming to you live from Louisville, Kentucky. And I'm joined by our editor-in-chief of TopMedTalk and my co-chair of this World Congress, my co-host, Monty Mythen. Hello, Monty. How are you?
Hey, Desiree. Great to see you. I'm just sorry to cut you off. I've just been handed a piece of paper to say that we've managed to get hold of Lee Fleisher.
On very short notice.
But he's got to go fairly quickly. So I suggest we jump straight in to say hi to Lee, and I'll explain the POCApalooza jazz later, if that's okay.
Absolutely. Lee, it is so wonderful to see you and catch up with you again. We talked last year around this same time. I know a lot has changed in your life recently. Lee, give us a little bit an update of where you are now and what's happening in the world of perioperative medicine.
Yeah, so thank you so much. And I think I even said that my life will be changing, but couldn't tell you what. I am the Chief Medical Officer for the Centers for Medicare and Medicaid Services, and I oversee the Center for Clinical Standards and Quality. So my job description says I'm responsible for the quality of care and safety of 147 million Americans in this role.
Oh my gosh. Congratulations, Lee. That is phenomenal. I can't think of another person who would do a fabulous job like you. So super congrats.
And what a great time to take on an easy job like that, Lee.
Well, since
you must sleep great.
Yeah, exactly. I spent essentially the first half of the last 9 months worrying about nursing homes. And thankfully, over the last few months, because we oversee all the 15,400 some nursing homes, in the last few months, thankfully, with the vaccine, we've really seen a difference.
Yeah. Well, Lee, we know this year has brought lots of challenges with COVID, but you are a true leader in this space of perioperative medicine here in the U.S. and abroad. And, I just kind of wanted to get a feel for after this year now, where, kind of what's the temperature on the ground as far in the U.S. when it comes to perioperative medicine?
So, it's an interesting question, and I can't speak specifically to what we're doing going forward, except for the stuff that's public. But I think, it was interesting that a lot of care was deferred during the pandemic, number one. And it really hasn't returned back to normal. We're just below normal levels or normal levels. I can't give you the exact data because we look at it all the time, at least in the Medicare population. But I think, Monty, the stuff you did in the UK of what's appropriate care is going to be a huge question. I mean, are we always doing, and how do we as anesthesiologists, anesthetists, ensuring that the right patient is getting the right operation? And maybe sometimes some of the operations that were done previously may not be necessary. So
yeah, and you've just, I know you can't say too much about it, but I'm sure we'll see the data in the course of time. You've just had a very interesting natural experiment.
Exactly, and it's been said by the director of the Center for Innovation, who I collaborate with closely on a lot of our models, is we're going to go more to mandatory models. And interestingly, you now have a U.S. physician at the NHS, Tim Ferriss, who he and I have worked together in various roles. And the question will become, if we get to more population health, will we be doing all the things? And, Sal's on this panel is all the stuff that Sal created at Duke and you, Monty, created even, were the leader of using the perioperative period as a time to improve individuals' health. Will that become the norm, as many of us hope we get to more population-based health and move away from fee-for-service, which is, one of the things that's been difficult in the U.S. So I think, that's the other thing that's really interesting is the role of anesthesiologists in emergency preparedness.
Yes.
In the UK, it's really well known. In the US, nobody thought about us.
Yeah. You mentioned that last time, Lee. I thought that was really just an interesting point. I mean, we really changed the view of anesthesia in the US for sure. Where do you think that's going to go? Is this opening new doors for us?
I think the question will be critical care, really how to think about that. And we all can't be, we hope this is the last pandemic, but most people are pretty sure this is not the last one, maybe not 18 months because of the mRNA vaccines and other things. But we really do believe, and my hope is that as we think, and the conditions of participation, which is what hospitals are required to do, include emergency preparedness. And as CMS starts to look at those questions, where do the CRNAs in my department stood up, and the anesthesiologists, where do we fit into being prepared for pandemics? Everyone thought of the medical ICU.
Yeah.
But we're the respiratory physiologists. So,
yep.
I truly hope we don't miss this opportunity to show that the versatility of our specialty is really important.
Lee, it's always wonderful to talk to you, and we'll have to set something up where we do a more thorough check-in with you. And I know you're super busy. Thank you for all the work that you're doing here in the U.S. and abroad as usual. And we'll chat with you soon, okay?
You got it.
What a treat that was, eh?
Yes, absolutely.
Yeah. And Lee, as in his role as editor-in-chief, will be coming back later today, we hope, if his schedule permits, but it's currently in the agenda, to do the editor's pick session, which is one of our very favorite ones, with Mike Grocott, etc. So I hope he can make it for that.
It is.
If not, we understand. I think the meetings you get in his position, the meetings you get put in the diary at short notice, you probably need to go to.
Probably so. You never know where those meeting invites are coming from. Well, Monty, let's go back and take a few steps back. Just as we this is the second year that we've done this. We've talked a little bit about it over the last year or so at our other meetings. But for those new to EBPOM, new to the World Congress, and new to TopMedTalk, tell us, POCApalooza, what in the world does that stand for?
20 plus years. Yeah, well, I'll answer that question. We're 20 plus years into evidence-based perioperative medicine. And I think we've made that transition from it being spoken about occasionally to becoming more recently a real thing, if that makes sense. There's a wiki page, so it must be real. So in last year, in planning this, we thought, well, actually, we now have a global community. How can we engage that global community? So we came up with this crazy idea of walking around the world to connect with various different countries to get an update on perioperative medicine. And in coming up with the title, we came up with a POCApalooza, because it's a term I heard in America for a sort of Lollapalooza or Data-palooza. I looked it up, and it's an extravagant event or party. So after we talk to our colleagues around the world, later on today in the meeting, we'll have our live streamed entertainment package, which again this year we have got Jeremy Sassoon. But now it's Jeremy Sassoon with friends. So coming with some of his colleagues into the studio and some other acts to give us a live performance to say, hurrah for perioperative medicine around the world. Now, last year, we were raising money for the African Perioperative Research Group. This year, we've asked people to buy tickets who come from well-resourced countries to enable us to give tickets free to the low and middle income countries around the world. And that's working very, very well as a model. So everyone who's bought a ticket, thank you. You are by default buying some tickets for colleagues elsewhere in the less well-resourced world. So that's our POCApalooza. Enjoy.
That is fantastic. Well, without further ado, Monty, we check in around the world, and we just heard from Lee Fleisher. We also have one of our partners in EBPOM USA, Saul Aronson. He's also a co-chair of our meeting today, the World Congress. So, state of the world right now, or state of the U.S. when it comes to perioperative medicine. Where are we right now? Obviously, COVID is the huge factor in all that, but just as you do.
Yeah, well, It depends in this country on what zip code or region you live in. I think, we all have heard, and it's certainly true, that some states are very efficient in rolling out the vaccine and some are less so. I think in general, the attitude is sort of crawling out of this craziness, and that's reflected by resumption of normalization of scheduling surgery. Many institutions have now forfeited, if you will, the prerequisite of having to have patients be COVID tested, which certainly greases that pathway a lot. And there's a resumption of normalization. I think some of the points that Lee just mentioned in his last session are well taken, whether or not we're back to where we were and whether or not we should ever, frankly, be back to where we were are questions that we're going to wax and wane philosophically for years to come. But I think we're in general relieved that we're definitely seeing a trend toward normalization and routine as we once knew it. I think we can pick up on that in the follow-up, but I would say that's my broad stroke of perspective right now.
Well, let's go ahead and bring in our other guest. We have Professor Carol Peden, who joined us last year for POCApalooza. She was out on the West Coast, but Carol, you had some changes as well.
Yes, we managed to relocate. My husband changed jobs, so we moved to Chicago in the middle of the pandemic. We drove across the US, which was fun. We had to avoid places like South Dakota with the Sturgis motorcycle rally right in the middle of that. So it was exciting. But yes, now in Chicago, where the big concert Lollapalooza is.
That's right.
And they're actually going to have it this summer, I believe, in some form or another.
Interesting.
So may I ask, Desiree, I've heard about the Lollapalooza, but what is it?
It's a huge concert. I think normally
music and festival and everything.
Half a million people.
Yeah.
So I must confess, this will be the first year in the last 7 that my wife and I have not attended. Now, mind you, it's a concert that attracts a demographic between 18 and 23 year old. Let's just say adolescents. But there is a VIP section where the 60 plus year old hippie generation sit and hang out over the stage and watch music. And it's a 3 or 4 day music festival with all the accoutrement that go with it. A lot of fun in Chicago. I don't know that I'm sad that we're not going this year, but in years past we did.
Well, I will tell you, that's what we're aiming for, right? With the POCApalooza, Monty, days and days. Awesome.
We were hoping that by this year we'd have 7, 8, 10 countries connected, having their own meetings anyway. But to align that time wise, but also then you'd have a sort of rolling entertainment program going on around the globe in the right time zones. We'll get there. We'll get there.
Yeah, for sure. Well, Carol, just give us a little bit more about your background, where you came from and what you were doing in California before you left.
So I worked virtually for the University of Southern California in Los Angeles till the end of September. But I was a professor of anesthesiology there and director of health system innovation. So I was overseeing the population health program, helped set that up there for the whole organization, just not just within anesthesia and surgery, and also the telemedicine work, which we've talked about and which we scaled up rapidly. And we've just submitted a paper on that showing actually we increased access for all patients with telemedicine, including those, from lower socioeconomic groups and those people whose first language was not English. So some other groups have not been finding that. So that was something that we did achieve, which is great news. And I think something we can build on in the perioperative arena. Some of it is about whether we do telephone or virtual calls. And we have to, I think, more research about, particularly in our arena, about the value of seeing somebody as opposed to just talking to them. And I think that's a big area for research going forward. I'm currently not officially working, although I am working within my adjunct roles as a professor at USC still and at Penn. And I've been continuing in my role as chair of the American Society of Anesthesiology Brain Health Initiative, which we can talk about in a minute. And also we've just published some new ERAS guidelines. So that's what's been keeping me busy.
You slouch.
And the book on perioperative medicine.
Oh, and the book. Yeah.
So Carol, can I just ask you a quick question? You've been in Chicago now for how long?
Since August.
Cubs or White Sox?
I'm not sure, but I think White Sox, is that the right answer?
Well, it depends on what side of the city you live in. No, that was wrong.
Oh.
Lou Malnati's or Giordano's?
I have no idea. So.
Oh, Carol, we'll have to talk later.
We'll do a cultural tour next time, Carol. We're down at Salk and
we'll have to come. But I think you have held meetings in Chicago. It's such a great city.
Yeah.
Sol's a resident.
Yes, we do, and we will.
Yes. Well, Carol, you have been doing so much work. Let's kind of continue that conversation from last year when we were talking about telehealth. And just briefly, I mean, you gave the good background there, but the scalability, I think you just mentioned briefly on that. As we are trying to resume surgery and get through the backlog and try and get to our patients a little bit more quickly. What do you think is the scalability of what you guys did?
I think this is huge for perioperative care. I think number one, probably a check-in, and Sol may be able to talk more to this, a check-in through telephone, and then, escalate some patients who we might have previously brought into a clinic to see them virtually, and more research into what we can and cannot do virtually. But I know that's happening, and including in the area of cognitive assessment. I know that people are working on that. And I think that there still is some of that digital divide between, people who are familiar with using telemedicine platforms and those that will need help. But I don't think we've always assumed a lot about what patients can't do. I think they can do a lot more than we always think. So I think breaking down those barriers and understanding what mode of connection we need for the first check-in and what we need to do for a more advanced assessment. But I think Sol's been doing some of that work.
I'll let Sol come in a second, if I may, Desiree. Did you get any sense of how the size of the hard to connect with population was? If you see what I mean, the digitally non-enabled, however we classify
well, as I say, in our study that we've just submitted for publication, we found actually, we switched to something like 80% of our patients connected through a virtual connection.
Yes.
And 60% of that, I think, was through telemedicine. So there was still a significant group, but which tended to be the older patients, but not always. And so again, I think understanding that and understanding what we need to do to help people is important.
Sorry, Sol.
Yeah, no, I think that is indeed what we found at Duke during the sort of most intense days of COVID, when people just were either not allowed or, much more reluctant to come into clinic. I think it's important that you parse out the definition of telehealth between phone connectivity and video, if you will, connectivity. Nearly everybody can be connected via phone. And what we learned is there were a whole lot of things that we can simply do well with that. The video piece adds value. And what's interesting is as our insurance colleagues were becoming more tolerant of that being an event where there was permissive charge capture, there was motivation on both sides to sort of develop that, technical constraints notwithstanding. But I do think it was a stress test to help us understand our capabilities to envelop that sort of layering engagement process. And that's true of all of medicine, not just perioperative medicine. So I think it's changed the way we practice forever, and it will have enduring effects.
Yeah. As my role at North Star Anesthesia, and locally, we use a system called EBPOM, and that actually went into play right as we were transitioning into COVID. And it's a system where everybody gets called. So the entire surgical schedule gets called, and then they level patients out to where we can, they just get test run, or we actually need to see them in person. We hadn't quite gotten over into the true virtual visit, but it worked so well. We were able to screen all of our patients and have a point of connection with them. So kind of pivoting off, Carol, some of the things that we had talked about last year, I kind of took those back to our team and talked to them a lot about that. So Carol, and just lastly, because I know this insurance piece, there's still a lot of questions with it. You worked locally too with your teams to get that covered too, if I remember correctly.
Well, I think it was covered under the CMS change with COVID. Yes. So yes. I know across the US there's now a move to ensure that stays because it's been so helpful. Prior to the pandemic, telemedicine was only covered for people in rural populations, whereas now, obviously, it's a norm for everybody on a day-to-day basis.
If I ruled the world, I'd incentivize it slightly, because if you look at the whole time lost to the population of struggling through everything and the carbon costs of traveling, I'd add a few percent. I'd do it the other way around.
Absolutely.
I don't rule the world, so everyone's all right for a while.
I think it's a great example of how the patient advocacy group has kind of demanded that it be more of a routine staple in the way that we manage patients. I think if it was left, and this is speculation, from a top-down decision, it would be less likely to persist as a reimbursable, if you will, action. But I think the patients have demanded that it become, a way for us to engage and a way for us to recognize the work that is involved in that engagement.
Yeah, because having, as we may all have been at one stage, been a patient or something equivalent thereof, the amount of time you give up to do it the hospital way. Yes. You kind of can't, come on, I'll chip in a little bit if I can do it from home.
That's right. Just parking alone.
Yeah.
Well, Carol, we had Lee on the call earlier, and he was talking about perioperative medicine and kind of where he sees it going. And we talked about population health. And I know that's something that you had specialized. Any thoughts on some of the comments that he was talking about?
Yeah, I mean, again, I think that perhaps another minor side effect, if you like, of the pandemic is the importance of making every touch point count. And, that connection, which I wrote an editorial with Monty and Tom Vetter a couple of years ago about, it's a time when patients and their primary care doctor perhaps are paying attention. And I know Sol's an expert in this, and use that opportunity to connect and look at things like smoking cessation, promote good health. Talk to the patient about how much better their outcome might be if we can get on top of some of these other things. So I think that there may be something to do with educating primary care. And I know there has been some work in the UK on this, but I wonder, and it might be interesting, Sol's thoughts on this, about connecting more with primary care about, don't send a patient for surgery until you've looked at some of these things, or talk about them simultaneously, but really harnessing those opportunities to make a surgical opportunity also a population health and a general health opportunity for care.
Yeah, I love that. So, I mean, your work, that's kind of where you guys were reaching out there, if I remember correctly. Is that true?
It is, and it continues to be sort of the passion and vision. Obviously emergencies and urgencies are dealt with emergently and urgently. So notwithstanding that dimension of surgical care, principally adult who are declared surgical and are to undergo elective surgery. The principle is, look, if you need surgery, you need surgery. Let's just sort of gloss over that presumption that you may not really need surgery, but for the moment, let's just presume that that's the truth. Our attitude is, but you should not have surgery until you're ready for surgery. There's nothing profound there, but it seems to be a paradigm shift that we as a population, as a culture, are having to adapt more and more of. And so our general approach is, let's screen much more carefully and proactively and diagnose much more thoroughly whether or not you're ready for surgery, and to the best of our abilities, balancing the impairment for surgery. What is the definition of elective is a whole nother scientific question that we've not addressed. Is it 2 days from now, or is it 2 months from now? And then get somebody as best we can teed up to undergo that sort of stress of the perturbation of surgery. And we've been very focused on that. I would just segue real quickly and say that in what we've learned as a society of healthcare and perioperative medicine is a consequence of COVID has been that fewer people have gone to the Red Cross to donate blood products. It's just a consequence of the nature of that beast. And so what we're dealing with now is there's a ubiquitous blood shortage in this country. And so if you think about the principles that we've been preaching in the narrow context of anemia diagnoses and preparation, it just makes sense that if you diagnose somebody who's anemic, who's likely to require transfusion intraoperatively if they're having a major procedure, all the more reason that you should get them ready for surgery by addressing their anemia before surgery. And that's just one example that's really, I think, come to the fore recently.
Yeah, I love that.
So Desiree, if I may, for 1 second, because this is our little chat show and I've always wanted to do this one. So Carol, you have a book coming out.
Yes. So
tell us about it.
Lee and Mike Englesby and I are the editors. Mike is a surgeon who's head of the Michigan Surgical Collaborative, and many of you will know that work, which is really outstanding. So we're doing a book on perioperative quality improvement, which many of you or members of your teams are authors in. And it's designed to be very user-friendly, short chapters, further reading. And so, yes, it's been a great opportunity to connect with old friends, and hopefully we'll be out early next year.
Yeah, fantastic. Practical approach, right?
Very practical approach, tools and techniques and clinical examples from people who've done the work.
Yeah. Well, actually, Monty, I was going to go to you and ask you about the state of perioperative medicine in the UK, but I think there's a good segue, actually. Carol, sorry to keep talking, but you said you had some recent piece come out on brain health and some of the work that you're doing there. Can you tell us just a little bit about that quickly as well?
Yes, well, American Society of Anesthesiologists Brain Health Initiative, Lee was the previous chair, I'm the current chair, has continued to be active. We've joined with the Committee of Geriatric Anesthesia within the ASA, which actually has been a great move and has been brought more of the frailty expertise in. So, and Dan Rubin at Chicago and I published an editorial a few months ago about this clearer overlap now between frailty and delirium and cognitive dysfunction perioperatively. So I think we have the ASA has forthcoming frailty tools coming out on the ASA website. With the Brain Health Initiative, we've had a lot of active webinars, which have been very well attended. At the end of last year in December, we had a more basic science-focused one. We've just had a State of the Union one with talks from around the country about what people are doing. We're doing one focused on the very practical paper we wrote in the BJA about the 6 things you can do, practical things you can do to focus on brain health. So that's been quite active. And for those of you who are listening, if you want to look at those resources, they're all on the ASA Perioperative Brain Health website. They're free to access, free to download, and we keep putting new podcasts on there, short practical pieces, and as much as possible, the up-to-date research literature. So do have a look at that. But we have continued to be quite active. And of course, one of the great things about what's happened with the pandemic is that we're all so much more connected. So we can have these webinars, and we hosted one jointly with the Chinese Society of Anesthesiology, the European Society, and the ASA. Of course, it was in the middle of the night for some people, but does increase access for everybody around the world.
Yeah, that's fantastic. I love it. I know we've talked a lot about those different things on TopMedTalk as well, so we can direct everyone to that and to the ASA and the work that you're doing there. So absolutely fantastic. Monty, before we wrap up, we of course want your perspective on perioperative medicine and what's happening in the UK.
I think perioperative medicine is going from strength to strength. I think obviously severely disrupted in one way by COVID-19, but on the other hand, highlighting the importance of perioperative medicine from the point of view of preparation and, getting enhanced recovery being done effectively. So I've just actually written an editorial called, and I don't know who originally said it, I'm hoping to credit someone at some stages, that the greatest healthcare innovation would be to just do what we know, which we struggle with, which is part of we've had this narrative documented since the turn of the century. We really need to get on and do it all now before we get to the very clever innovations. And as part of that, locally at UCL, we've seen the opening led by Professor David Walker of our own section of a floor, which has a surgical high care unit, surgical intensive care unit, which now has a full set of perioperative medicine attendings. So we appointed our first full set of 7 perioptimists, as they're referred to, supported by the old guys, and a full tranche of the most amazing fellows in that space. So we're very, very lucky. Increasingly, it's becoming a reality. Now, immediately they were taken off to do nothing but COVID-19 ITU, but they're just back in full flow. So lots to. Well, it's easier to say the bad things, but lots of good.
There is lots of good. And I just keep saying it's the silver lining. I mean, the conversations that we've had, there are a lot of silver linings through all of this. And Carol, I love what you said too, just about the connectedness. I mean, we wouldn't be doing this right now had the pandemic not happened. And I think, having these perspectives and being able to share all of those is so very important to continue to move the needle and advance it in ways that we never thought, or didn't think were possible. So for sure. Well, any other comments you guys want to talk about?
I just have to shout out for the ERAS guidelines on emergency laparotomy, which many of you will know. Emergency laparotomy has been my passion for many years, and led with those jointly with Mike Scott, who's now at Penn, and an international authorship from Australia, South America, Scandinavia, the US, and Europe. So please have a look at those. That's part 1. There was quite a lot to say, so we had to split it into 2 parts. Part 2 is coming soon.
Yeah, I saw those too, and so valuable right now throughout the pandemic when we know, where emergency surgeries are the ones, that we're tending to focus on. So I think that's going to be great information for sure. Well, guys, thank you so much for joining us. It's always a pleasure, Carol, to talk to you, and Saul and Monty for giving your perspective. Be sure, right, Monty, we have some entertainment, right? Part of POCApalooza.
We've got the editor's pick, which obviously everyone's very excited about, the journal choices of the year, with a tilt towards the journal Perioperative Medicine, I'm guessing, but there we go. But following that, we have our live entertainment, as I said, led by the wonderful Jeremy Sassoon, who the plan at the moment is to come into our studios in West London later today, and hopefully he's just parking up at the moment. And we'll have an actual live streamed session as a trio coming in. He's a wonderful jazz musician who we went to medical school together, but he had a change of career. And he is a jazz superstar. So he'll be doing.
Tell Jeremy hello from me on this side of the world.
Yeah.
TopMedTalk.
And if you missed anything from the POCApalooza or the World Congress, you can always go onto the EBPOM platform. We are going to have that content up there enduring, so you can see conversations that we've had with people from around the world about everything perioperative medicine. So thank you so much for listening. Enjoy the entertainment later today, and cheers.